Hello, and welcome to our online discussion of April 8, 2016. My name is Christian Debré, and this is Amy Asbrook, the director of Toujours Vivant, Not Dead Yet.
Hello.
Toujours Vivant, Not Dead Yet is a non-religious organization by and for people with disabilities and their allies. Our goal is to inform, unify, and give voice to the disability right opposition to assisted suicide, euthanasia, and other ending of life practices that discriminate against people with disabilities. Today's topics: MOLST Part II, which is
Medical orders for life-saving treatment.
Thank you. And filling out the form. This is the part 2. So I give the voice to Amy Asbrook, and we will discuss on it.
Okay. MOLST, Medical Orders for Life-Saving Treatment, Part 2, filling out the forms. After our discussion of Medical Orders for Life-Saving Treatment, Part 1, last week, we felt that something was still missing. We talked in general terms, but we didn't look at any actual MOLST forms. So this week, we obtained several forms from the US and Canada, and that represent a mix of MOLST and advanced directive orders. This way we can go over exactly what questions are on the forms and how the questions are asked. So that'll give you a better idea of what to look for in an MOLST form when you go to fill one out.
And the way you ask question is very influencing over the answer.
Right, exactly. The way the questions are asked.
The glass half full or half empty.
Exactly. So Quebec's and Ontario's forms were not available on the internet, though we did find a copy of a form used in nursing homes in Quebec. And I was not really surprised that we couldn't get Quebec's form. And you have to write to the health department to get Quebec's form. So you can't even fill it out online. And I couldn't find Ontario's form at all. So that was too bad. Though the forms are for life-sustaining treatment, many present the option of rejecting life-sustaining treatment first. And that's true for the New York form that says, do not resuscitate and other life-sustaining treatments, which is...
First question for life-sustaining.
Right.
Wow.
Right, do not resuscitate. That is not a life-sustaining treatment. Some of the forms offer the least to most life-saving care options in that order. For example, the Fraser Health form from British Columbia offers comfort care first and then moves up to critical care. So instead of talking about life-saving care first, it has the lowest level of care at the top, and that's not going to save your life. Comfort care is not going to save your life, and then it moves down the list to higher level of care.
You could not do best if you want to kill somebody.
Right, exactly. So the lowest level of care is offered first. It's like they're suggesting in the order of their preference what they're on the list. So the lowest level of care is sort of their top priority. Some of the forms talk about what the person doesn't want, while a few, such as the form from the Regina Capel region in Saskatchewan, is phrased in terms of what the person does want. So again, it's how you phrase the question. Is it half full or is it half empty? Is it what the person wants or is it what the person doesn't want? You have to be careful when you look at those forms, and it's for both filling them out, and also if you find one in your medical record, you have to make sure that it's filled out the way you want it to be.
Yeah, it is very important to read it.
Right. Some forms offer life-saving treatment on a trial basis. This means that all measures would be taken to revive a person, then would be withdrawn later if the person wants them stopped, if she does not appear to be responding to treatment or if her condition is getting worse.
And there is a very significant example of
that. And his name was Tim Bowers, and he was hunting and fell out of a tree and got a spinal cord injury. And so they brought him to the hospital and they put him in a coma, and then they woke him up from the coma and told him that he had a high-level spinal cord injury and he would never be able to hold his child, and he couldn't do this and he couldn't do that. And then they asked him, so do you want us to continue treatment? And he said no, because of the way they had described how his life would be. So that's an example.
Instead of saying, okay,
right,
for saving your life, we have to do that. Do you want it? And
right,
when we save your life, you will be able to do that again.
Right,
which
exactly.
is not the way they do it. They present the glass half empty.
Yeah. They presented all the negative things without presenting any positive things. And so he had a very negative view of his life at that point. And so he decided to have all the life-sustaining treatments turned off, and so he died, but he didn't need to die. So the CPR, cardiopulmonary resuscitation option is usually the first item on the list. The New York and Massachusetts forms offer do not resuscitate as the first option, but most others put attempt resuscitation first.
Which is quite a lot better.
Yeah, that's a lot better. If you offer the positive option first, it's better than if you offer the negative option. And again, the one that they put first is usually the one that they're pushing. And that sort of gives you an idea of where they're coming from. Sometimes the option of no intubation is offered, so that instead of having a breathing tube in your throat, only a breathing mask that provides positive airway pressure would be used. This choice is available on the Fraser Health form and several forms from the US.
Both of us already use positive pressure mask.
Right, exactly.
Because we suffer from
sleep apnea.
Yeah.
Yeah. And it's not very invasive, and it's very, you get used to it, it's not a problem. But being intubated is a lot more invasive, but it's still, if you need to breathe, it's necessary. And some people end up having tracheotomy afterwards if they still need to breathe and they can't breathe through their mouth. So, but lots of people live with that, and
a lot. I know at least one people who had to plug the hole in his throat to speak, and when he stop to speak, you just breathe again.
Right, and I know lots of people who have tracheotomies, and they don't have to plug the hole, but they have a breathing tube in their throat. So most regions seem to offer 3 levels of care, but some offer 5, or some offer, I think 3 and 5 are the numbers that I've seen most. The first level, the highest level, is do everything, including CPR, cardiac defibrillation, which is the shock, and intubation.
But one thing that people must understand, asking for the most treatment doesn't mean they have to do over-treated, okay?
Right. It doesn't mean that you're always going to get over-treated, and you can, like they said, you can have it for a little while and then you can stop it whenever you want. It doesn't mean that they're going to drag it out forever. It's up to you. It's just a matter of what happens immediately, and you can make a decision later on to stop the treatment.
Yeah, you could always stop anytime, but you have only one chance to say, I want to be treated.
Right. And also, CPR in the hospital is only effective about 17% of the time, and it's less effective the older you get, and if you have heart problems or cancer or something else going wrong with you.
Yeah, but when it succeeds, most of people have long years to live after.
Right.
I have a friend of mine who have many times more than 12 days in coma, and he's still living and having a good life.
Right. There's lots of people who've had heart attacks and who've been revived. That doesn't mean that it's very common, but if you ask for it, you're going to get it, and you have a 17% chance of surviving, whereas if you say no...
A lot better than zero.
Right, it's a lot better than zero. So the second level of care is an elevated level of care, which includes some services but not others, and we'll go into that in a minute, what those services are. And the lowest level is comfort care. But like I said, a lot of hospitals present comfort care as the first option, and that's the lowest level of care. That's just for people who don't want any intervention to save their lives at all. They just want to die and be comfortable while they're dying. The services that make up the higher levels of care include transfer to a hospital, which applies both to people in long-term care and at home. If the person does not want to be resuscitated and just wants to die at home, she can refuse to be taken to the hospital. So that's a perfectly reasonable option if somebody wants to do that. Another higher level care is artificial, in quotes, artificial nutrition, which is feeding a liquid diet through a tube that is either inserted in the esophagus via the nose or through a gastric tube surgically inserted directly into the stomach. Refusing artificial nutrition means the person will die of starvation within a few weeks, depending on her health. So if it's a very healthy person, it'll take a month or a little more. And if it's not a very healthy person, it'll take less than that. Artificial hydration, quote unquote, is when fluids are given intravenously instead of by mouth. Refusing fluids means the person will die of dehydration within 5 to 7 days, or about that.
It's quite fast.
Right, it's pretty fast. It's not very pleasant, but they can make you comfortable by putting ice chips in your mouth so that your mouth doesn't get too dry.
And anyway, dying is never pleasant.
Right, exactly. And most people who do that are sedated while they're dying.
Yeah.
So transfusions and other blood products are another service in the higher level of services. And they're given if a person has lost blood or if there's something wrong with the blood. Refusing blood or blood products can cause death within a few hours or days, depending on the problem. So if a person has lost a lot of blood, they'll need a transfusion, or if the person needs platelets, or if a person needs blood plasma, or any number of things, there's lots of blood products that can be administered. And again, depending on what's wrong with them, it will take more or less time to die if they don't get it. Kidney dialysis is needed when the kidneys are not working properly. Dialysis cleans toxins and impurities from the blood that would poison a person if it were not done every few days. Refusing dialysis would cause death in a matter of days or weeks, depending on the level of kidney function. And again, that's if a person is kind of healthy, but the kidneys are just shutting down, they might survive for a few weeks, but if the kidneys really are not working at all, they would only survive a few days without dialysis.
And anyway, dialysis is only a filtering. It's a filter. They pass through the blood. The blood passes through a filter and cleans out the toxins, and you have to sit there for a few hours at a time to let that happen. And it happens a few times a week, and it takes a lot of time, but it's the difference between dying and not dying. A lot of people have survived a lot of years using dialysis. Right, exactly. And because now kidneys can be transplanted without killing the person who's giving the kidney, people can get kidneys from family members
for an easier match, and you know, people can survive on one kidney. So that's another option. Antibiotics are necessary to cure infections. Refusing antibiotics will only cause a problem if you have a bacterial infection, such as a urinary tract infection, an infected bed sore, C. difficile, pneumonia, or other hospital-borne bug, or any of which could cause death if untreated. So antibiotics are another service that's at the higher level of care. And if you refuse that care, you could die by any number of those possible infections. What is available at higher level of care is different in each region, so it's important to read the form carefully to know what services are available at each level of care. And sometimes it can be kind of confusing, and we'll get to that in a minute. Comfort care is medical care and treatment provided with the primary goal of relieving pain and other symptoms and reducing suffering. It includes reasonable measures to offer food and fluids by mouth, including spoon feeding and liquids via a straw. And that can be very helpful. The only problem is that if it takes you a long time to swallow and chew, usually the food is very soft, but if it takes you a long time to swallow, the person who's giving you the food may not have much time to feed you, and so you might become malnourished if you're getting food by mouth that way.
The personnel doesn't have time now.
Right, exactly. So sometimes they'll order a feeding tube because it's faster for them. If the person has a feeding tube, they can just set it up and let it run until the feeding liquid is done. Administering medications by mouth, or in some regions by IV. So that's a comfort care service. And some places will administer medications by IV, but generally it's by mouth. Another comfort service is turning and positioning the person to avoid bed sores.
Very important for old people.
Yes. Well, for anybody who can't move, because if you're paralyzed, you can't move. So it's very important to be turned every once in a while to avoid bed sores. They will provide caring for wounds for comfort care, and also providing oxygen and suctioning if the windpipe becomes clogged with secretions like saliva or mucus that gets into your windpipe and you can't cough it up and swallow it. So they'll suction your windpipe. As we said last week, a doctor is supposed to discuss these options with the person who has a terminal illness. Help her fill out the form, witness her signature, then sign the form attesting that the discussion took place. The form is then put in the person's medical record and should be followed by staff if the person cannot consent to care.
Should be followed.
That all should happen. And as we said last week, it doesn't always work out that way.
It happened that it's not respected.
Right.
It happened a lot that the doctor doesn't discuss it with his patient.
Right.
And sometimes the doctor doesn't even know really the patient.
Right. Sometimes the doctor doesn't even sign it. Sometimes it's a nurse that writes it out. So also, when doctors are describing these treatments, they often put a negative spin on them. So, for example, instead of describing tube feeding as a medical technology that enables people to live normal lives, they may describe it as very medical terms that make it sound undignified. And there's nothing undignified about using a feeding tube.
Nothing at all.
And lots of people use them, and it makes them able to live independently, whereas they couldn't otherwise. It's important to remember that doctors only see people when something goes wrong at their worst in the hospital. They don't see people, even people with feeding tubes or using ventilators, living their everyday lives out in the community.
But it's happening. A lot of people do that.
Right, exactly. But doctors only see people at the worst times in their lives, and so that's how they think of people, as desperately sick and unhappy.
When they use the whole thing, which
Right.
is not always the case.
It's not accurate. It's not,
Not
an
accurate
accurate way
at all.
to look at it. One problem we found with the MOLST forms was that they were not specific or confusing as to what treatments were required for each level of care. For example, with the Quebec form, level 2 care requires, quote, correction of any reversible deterioration using the resources available at the facility. Transfer to a hospital as needed, unquote.
Resource available to
At the facility.
at the facility, which means what?
Right, exactly.
The defibrillator is 4 rooms away. You will run to save the life of the patient. It's available, or you doesn't run and it's not available.
Right, exactly.
It's at the same place. It's just depending of the people who are there.
Right. Also, it does, other than saying transfer to a hospital as needed, it doesn't describe the services that are appropriate for that level of care. It doesn't say whether the person would get IV drugs or not. It doesn't say whether the person would get tube feeding or not. So all of those things are not described. The Georgia forms limited additional intervention includes, quote, comfort measures and medical treatment, IV fluids, and cardiac monitor as indicated. Does not include intubation or mechanical ventilation. Avoid intensive care. Transfer to hospital if indicated. So you have to refer at the beginning to what the comfort measures are. And
It began to be
then
very
you have to
complicated.
go look somewhere else on the form. It gets complicated. Then it says you do this and then you don't do that. This definition requires you to refer to the comfort care guidelines, then includes both do's and don'ts. So it's very confusing for somebody on the staff who's trying to figure out what care to give this person. They have to look elsewhere. They have to say, do this, don't do that. It's hard to figure out. It's confusing. As we said last week, it's crucial that patients and their families be vigilant in checking to see if there is a DNR, do not resuscitate, or MOLST form in their medical charts. Verify what is written on the form and demand that it be changed if it doesn't agree with their wishes. That's very important. It's the most important thing that we can message that we can give, because all of these forms, every one is different. There's no standard form, so we can't put up on our website one standard form and say that's the form you're going to find. You have to check to see if there's already a form in your medical chart and look and see what's written on it. If there's a do not resuscitate
and be
form.
aware, you have to check many times in many places, because it could still have some paper saying do not resuscitate or thing like that.
Right, exactly. Even if you filled one out a long time ago, it's still going to be there. And even if you revoke the form, you may have to revoke many different forms from many different places, and you have to make sure that it's taken away from all the places or changed. If you make changes, you have to make sure those changes are recorded on every single form. And that could be difficult, because it could be an electronic form and paper form in different places. So it's very important to be vigilant about that. And it's too bad that people have to do that for themselves instead of being able to trust the medical establishment. But the medical establishment is there to run like a factory. It's not really there to take care of individual people. It's there to take care of sickness. So, let's see what time it is. Okay, I just wanted to check my time here. There are many reasons to oppose legalization of assisted suicide and euthanasia. Here are just a few. First, because it's unnecessary. Everyone has the option to commit suicide or to refuse medical care and to have palliative sedation on demand.
And we have proof of it.
Right, exactly. We have proof that all of these things, the do not resuscitate order, all of these are ways that people can refuse medical care, and those are all legal right now. So we don't have to legalize assisted suicide for people to be able to refuse medical care. And the hospitals make it very easy to refuse medical care. So
they are happy to do that for you.
Right, exactly. Also, it's discriminatory because while people without disabilities receive suicide prevention services if they express a wish to die, people with disabilities will be encouraged and assisted to kill themselves. And that's discrimination. That's a deux poids, deux mesures, double standard.
Yeah.
Sometimes the French phrase comes first and I can't get the English one. Also, choice is an illusion. The choice to die cannot be free as long as people with disabilities don't have the choice in where and how to live. And because of discrimination, lack of access to home care, and architectural barriers in housing, people don't always have a choice of where and how they live. So in that case, the choice to die is not really free. And finally, safeguards don't work because where assisted suicide and euthanasia are legal, safeguards do not prevent people with disabilities from being wrongly killed. So, to view our videos, you can go to YouTube or the search engine of your choice and put in the terms euthanasia and disability, and you'll find our videos. We have easily. You'll find 2.5 years worth of videos that we've done already. Each of them is about a half hour long, and they cover all kinds of subjects, and usually the subject is written in the description, so you can find out what the subject is. To participate live, send me your email address and I will send you a link to join us, and that will arrive about 15 minutes before the program starts. And you can send me your email address to info@tv-ndy.ca. For more information about the subjects we talk about here, go to our Facebook page at facebook.com/toujours vivant, not dead yet, all one word. You can also go to our website at tvndy.ca. Email us at info@tv-ndy.ca, or you can follow us on Twitter @TVNDY. Thanks for being with us, and thanks to Christian for helping out.
Thank you, guys.
And please join us again next week.
Take care.
Goodbye.
Bye.